Okay, good morning, everyone. I hope you're all doing well and staying home and staying safe. So today I am here to deliver my three-part lecture, first part of my three-part lecture on odontogenic tumors. And since this is the first voice over recording that I'm doing, let me know how this goes. And if you have any problems at the end of the lecture, please feel free to send me either a message on the e-learning portal or on the Google Classroom so that we could discuss if there's anything that you haven't understood. All right, first of all, with respect to odontogenic tumors, I always stress in my lectures that this is one very important topic for dental surgeons, and it is in year 3 that it is introduced for the first time. A little bit of it you have already come across as part of your teaching and learning in general pathology, and this is one topic which is exclusive to dental surgeons, and you are the master of it. Many of our health professional colleagues, especially in the medical side, would have very superficial information or knowledge about it. So this topic, please pay attention to it. We need to master it well so that when you are in dental practice, you will be able to make informed decisions. All right. So first of all, as is usual for our outcome-based curriculum, these are the learning outcomes of this topic. So as I mentioned at the beginning, this will be a three-part lecture, and I will be covering the most important lesions. The rest of them you would have to read up, and if you have any doubts, you can always ask me. All right, so by the end of this topic, you should be able to classify odontogenic tumors, right? So this classification I will go through with you as part of this lecture in detail. I will also tell you why this classification is important and how it is slightly different from some of the other classifications that were discussed in the past. Second, you should be able to describe clinicopathological aspects of odontomes, ameloblastoma, unicystic ameloblastoma, CEOT, which stands for calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor, which is AOT, and CEOC, which is calcifying epithelial odontogenic cyst. Thirdly, you should be able to describe in brief cementoblastoma and ameloblastic fibroma. You should be able to identify and illustrate the histopathology of ameloblastoma odontome, CEOT, AOT, CEOC. And lastly, the most important one from the practical and the clinical practice point of view is you should be able to recognize the importance of histopathological diagnosis of odontogenic tumor and outline the rationale behind various treatment options. All right, now the last outcome you will be able to achieve only if you pay attention and read this topic and understand the science, right? Because as I always mention, pathology is the science behind the cure. So if you are able to give a rationale for what treatment you are going to give for a particular pathology, you first need to understand the pathology in detail. All right, so with that, let's start. Okay, so I thought as an introduction to this topic, I would just run through some of the slides, histological slides of something that you learned in year 1 as part of oral biology. So I believe this picture is quite familiar to most of you. This is the picture of the enamel organ, basically the embryological development of tooth, right? So you see the enamel organ over here, and you also see the, I'm sorry, let me just look at, yeah, okay, right. So you see the enamel organ here, right? And you're seeing the ectomesenchymal condensation over here, which is the bud stage, right? And this is how it invaginates from the oral epithelium as part of the initial stage, right? This is the cap stage, right? Wherein there is formation of, you are able to appreciate the oral epithelium, the enamel organ, and the bone around, right? And this is the most important part, where you must have drawn quite a lot of these diagrams in oral biology, where you actually see the differentiation of the entire enamel organ into various epithelial various components of cells which actually give rise to various components of the tooth, right? So the RDL actually stands for the res of dental lamina, the SR stands for stellate reticulum, right? The outer enamel epithelium over here, the inner enamel epithelium over here, the EM, which stands for the ectomesenchyme, right? So just to make you familiar, these are the primitive cells that actually give rise to the various parts of the tooth. Okay, now how is this important here at this point? It's important because when we discuss odontogenic tumors, uh, odontogenic tumors, just like any other tumors, okay, are arise from these primitive cells. Okay, who gets these tumors, who does not get these tumors? Again, just like any cancer, uh, just like most cancers, we do not have a specific answer to them. Okay, advancement in research today is able to bring us information that tells us that there are certain mutations that take place in these cells that lead to the formation of certain tumors. Okay, but what are the predisposing factors, so on and so forth? Right now, in terms of odontogenic tumors, we do not have a specific answer. All right, so with this uh, brief intro of or refreshment of your knowledge of oral histology, let's look forward and see. Okay, this is again uh, um, uh, a high power picture of the parts of the enamel organ, differentiated part. This is the dental follicle. You're seeing the stratum intermedium. You're seeing the inner enamel epithelium, the outer enamel epithelium, the stellate reticulum, the dental papilla here. So this is what gives rise to the pulp. This structure is what gives rise to the interface between the dentine and the enamel, right? And remnants following the formation of the enamel and dentine, basically enamel, dentine, and the pulp, there remains there's a huge lot of remnants of epithelial cells that are present inside the maxilla and the mandible. Okay, in the past I have mentioned that maxilla and mandible, unlike any other bone in the body, are the only bones um, which have teeth in them, first of all, and also have a large number of rest cells, that is the remnants of cells that gave rise to the tooth structure. Okay, in all the other parts of the body, the other parts of the body where there are bones, the bone does not have epithelial cells entrapped within them. Okay, so that is a huge difference. Okay, and these entrapped epithelial cells uh, are the progenitor cells for the various odontogenic tumors. Okay, as we will look uh, forward in this lecture. All right. Okay, so let's look at the WHO classification for odontogenic tumors. So just like most other tumors, the World Health Organization also every 10 years comes up with a review of the classification for tumors. All right, so the last classification, the latest one is 2017. Prior to that, the one that we used to discuss with your senior batches was 2007 classification. So I have retrieved this from the WHO website, and I thought that this is we will use this as a template for our discussion, because number one, it's been further simplified and made much more easier. Okay, so please don't follow the notes that your seniors have been following, because the classification at that time was a little more complicated given by WHO, and we used to insist on you working on that classification. But I think now we have a simpler one, a much easier one. So let's try and work this out. All right, so just like any other tumors, they're classified as benign odontogenic tumors and malignant odontogenic tumors. So first of all, benign odontogenic tumors, you have epithelial in origin. Okay, so tumors that arise from the epithelium, basically. So when we say the epithelial in origin, okay, so we're basically looking at this. You're looking at the cells, the cell rests that are epithelial in origin during the tooth formation stage. Okay, and the most important tumor that arises from which is in purely epithelial in origin is an ameloblastoma. Now, ameloblastomas are categorized as conventional. They're categorized as unicystic type. They're categorized as extraosseous or peripheral type, and they are categorized as metastasizing malignant ameloblastoma. Okay, please take note that even though in the new classification, the metastasizing malignant ameloblastoma is now categorized under benign tumors. Okay, even though it is the word malignant is here, it is still classified as benign. Okay, I will explain it to you as we go through this topic of ameloblastoma. Okay, so this is number one in the list of epithelial tumors, or epithelial tumors which are benign. Number two is squamous odontogenic tumor, okay, which is again a specific type of lesion. Number three is calcifying epithelial odontogenic tumor, and then number four is adenomatoid odontogenic tumor. Okay, okay, right. So okay, so this is the mixed odontogenic tumor. Okay, this is the list of mixed odontogenic tumor. Mixed means epithelial in origin and mesenchymal in origin. Under that, you have ameloblastic fibroma, you have primordial odontogenic tumor, which is a new tumor. Okay, I think you can see this pop out. I've just added this as part of notes because this is some information. This is a new type of tumor quite recently classified. Okay, this is the information about it. And then odontomes, which are actually the most common odontogenic tumors classified as compound and complex. And then you have dentinogenetic ghost cell tumors. Okay, so this group of tumors have a mix of epithelial origin and mesenchymal origin. So if you look at the enamel organ, the pictures that we just saw, okay, they arise from the epithelial component as well as the dental papilla, which is the mesenchymal component. The third group, which is the mesenchymal origin, purely arises from the mesenchymal component. That means the dental papilla cells. All right. So under that you have odontogenic fibroma, you have odontogenic myxoma, myxofibroma, cementoblastoma, and cementoossifying fibroma. All right. So this is basically what I was meaning. What it means when you say odontogenic epithelial in origin and odontogenic mesenchymal in origin. Okay. All right. Right. The last group is the malignant odontogenic tumors, and all of them have been classified, categorized as together, okay, carcinomas and sarcomas together, okay. So under malignant odontogenic tumors, you have amelobllastic carcinoma, you have primary introsseous carcinoma. NOS stands for not otherwise specified, okay. Sclerosing odontogenic carcinoma, clear cell odontogenic carcinoma, ghost cell odontogenic carcinoma, odontogenic carcinosarcoma, and odontogenic sarcomas. All right. In terms of uh, undergraduate curriculum, malignant odontogenic tumors are very rare, and it is good to be aware of these lesions. You do not need to um, go into the details in depth. All right. Okay, so let's start off with the first lesion of epithelial origin, which is ameloblastoma. I would like to discuss this first because we will start off with epithelial. We will follow the classification in our lectures. That means we will first do all the epithelial tumors, then the mixed, and then the mesenchymal tumors in the end. All right. So also in that sequence, I will be covering the most important lesion based on their frequency. Okay. So number one is ameloblastoma. So just for your information, it's been defined by Robinson as a usually unicentric, non-functional, intermittent in growth, anatomical benign, and clinically persistent. Okay. Now this definition I have, you don't need to memorize it. It's a definition that clearly describes the behavior of this tumor. Okay, that means it's unicentric. That means it's generally begins at one place in the jaw. Okay, it's non-functional, it's intermittent in growth. That means you do see phases of extended growth, and then you see phases of no growth at all. That means the size of the lesion remains static. It's anatomical benign, but it's clinically persistent. That means it continuously will grow if it's not treated. Okay. All right. The present term, which is ameloblastoma, was suggested by somebody called Churchill in the year 1934, and which replaced the old term, which was adamantinoma, which was given by Melezis in the year 1885. Okay. Now, you must have come across the term adamantinoma in general pathology in year 2. The accepted terminology today is ameloblastoma. All right. Okay, incidence is 11 to 13.5% of all odontogenic tumors are ameloblastomas, and for your information, is the second most common odontogenic tumor. The average age is 28 to 42 years. Males and females are equally affected. Okay, now for site distribution, I really like this diagrammatic representation here because it clearly uh, leaves an imprint here. The most common site, if you look at it, is in a study that was done on 391 patients. 224 of them were from the mandibular posterior region, that is the molar premolar region. Okay, so that is the most common site, and this is something that is found in most studies across the globe. Okay, the second most common site is the maxillary posterior region. Okay, followed by the mandibular anterior region, and then the maxillary anterior region. Okay, so this is the frequency of site distribution among of cases in ameloblastoma. So common clinical features, generally it's asymptomatic. Patient is asymptomatic who presents with a painless slow growth. Okay, it presents as a swelling, and the other effects could be other effects of the swelling could be displacement and mobility of teeth. Rarely it can ulcerate through the mucosa. You will be able to appreciate it when I show you the clinical picture on the next slide. Okay, all right, radiographically, all right, 85% form rounded, well-defined multilocular cyst-like radiolucencies with well-defined margins. Now, so it is a radiolucent lesion, right, with well-defined margins. All right. I always like to stress here that whenever we have a lesion which shows well-defined margins, it indicates to us that it is a slow-growing lesion. That means there is sufficient time for the lesion to actually produce uh, sclerotic bone around as a defense mechanism around the expanding lesion. All right, that is not the case in a malignant lesion or an aggressive lesion, because the aggressive lesion proliferates at a faster rate compared to and does not give the body time to be able to produce that defense mechanism bone. All right, so this clearly indicates that this lesion is benign. Okay, radiographically as well. So variants of this include soap bubble appearance and honeycomb pattern. Now I've highlighted that in red because that is a specific term that is used to describe the radiographic features of ameloblastoma. Okay, right. So this is the first picture that I have posted here. I hope you're able to appreciate the asymmetry here. The person here has a swelling on the right side over here. Okay, if you could notice here, right? This picture, a second picture of a girl here, and the swelling is even more prominent here compared to the first slide, compared to the first case. And then a third case where you can obviously see the massive extent of the swelling. Now, if you look, the reason why I have put this picture is for you to understand that this is, as the definition goes or the explanation goes, is a slow growing, right? Is a slow growing lesion which is benign but is clinically persistent. This is exactly what this means, right? So it is grows slowly, so it expands slowly. So the reason why it can actually attain massive sizes is because there is enough time for the body, for the normal parts of the bone to expand as the lesion is proliferating. Okay, that is the reason why you're not seeing ulceration over here. You're not seeing uh, other features that you would see in a malignant lesion in its clinical appearance. Okay, so this is how big and massive this tumor can grow because of its nature, right? Okay, radiographically, the features of ameloblastoma, you can clearly see this is the radiolucency that you are seeing. These are different lesions from these are radiographic images of different cases, but just to show you the lesion here. So this is the extent of the lesion here, right? This is a lesion that is seen in association with an impacted tooth. Okay, and here in this particular slide, you can clearly appreciate the soap bubble appearance. Okay, so if you can see, this is the part that clearly shows the soap bubble appearance. Okay, Right. Okay, this is an image of a resected specimen of an ameloblastoma. So this was a case which had an impacted tooth, and this impacted tooth actually went on to give rise to this multilocular radiolucency, which turned out to be an ameloblastoma. So if you look at this, look at the extent look at the extent of this lesion. This is a massive lesion extending right from the coronoid process right until uh, the base of the mandible here, right until the posterior extent. This is a massive lesion. So this is how destructive it can be, even though it is a benign lesion. Okay, so now we know about the common clinical features. We know about the radiographic features of this lesion. We know that this lesion is clinically persistent. It is unicentric, it's non-functional, benign in nature, but can grow to massive size. Right. So the most important part histologically that we need to understand is that this lesion has can present as six histological types, which have distinct histological features, and it is important for us to categorize them histologically because the prognosis kind of varies. Okay, that's something that we will discuss. So the first histological type, and the most common one, is the follicular type. Okay, I will show you and we will discuss. The second is plexiform. You have something called as acanthomatous. You have something called as granular ameloblastoma, and then you have basal cell ameloblastoma, and the sixth one, which is called as the desmoplastic ameloblastoma. Right. Now, desmoplastic ameloblastoma, I have actually highlighted it in red because it is a type of ameloblastoma which has very distinct clinical and radiographic features, entirely different from the five that I mentioned here. Collectively, all of this come under the category of conventional ameloblastoma as per the WHO. I hope you have understood what I'm trying to say here. Okay, so let's look at the follicular ameloblastoma. Now, first of all, the word follicular. What does the word follicular mean? It means any histological presentation which looks like a secretory gland. Okay, a secretory gland. That is what is the meaning of the word follicle. So in this particular type of ameloblastoma, the arrangement of cells, okay, the arrangement of cells that is seen here is more like a follicle. So I'll explain that on the next slide. Unfortunately, when I'm recording this slide, I can't go back and forth unlike a real class. So please bear with me. So let's run through these features here. So it's the most common type and most readily recognizable, something very easy to recognize and identify histologically. It consists of islands or trabeculae of epithelial cells in connective tissue stroma. Okay, the island consists of loosely arranged polygonal or angular cells resembling stellate reticulum surrounded by a single layer of tall columnar ameloblast-like cells with reverse polarity. Okay, and you see a lot of cyst formation. Okay, I'm going to actually try and draw something here so that you could actually understand what this particular statement means. That means the third particular statement. Okay, so I said you see basically follicular arrangement. Now, in a follicular arrangement, basically you see arrangement of cells in a island. Okay, now this island generally has tall columnar cells like this. It's amazing that I can actually use the pen and draw something so nicely. I never knew that we could do this. All right, so these tall columnar cells, all right, these tall columnar cells um, are basically the ameloblast like cells. Okay, the best part is the nuclei is generally arranged away from the basement membrane. You understand that? Okay, the nuclei is away from the basement membrane, and in the center you generally see stellate reticulum like cells. Okay, this is the common arrangement. Okay, that's what this one. Island consists of loosely arranged polygonal or angular cells resembling stellate reticulum surrounded by a single layer of tall columnar ameloblast-like cells with reverse polarity. The word reverse polarity means when you have basement membrane, you have tall columnar ameloblast-like cell, but the arrangement of the nuclei is away from the basement membrane. It's not towards the basement membrane. That is reverse polarity. Okay, collectively this is actually described in text as Vickers and Gorlin's criteria to be able to identify ameloblast like cells. Okay, so that is good to know for you. All right, so let's look at this. Now this is a low power image of a follicular ameloblastoma. Now if you look at this, this is the follicle, okay, which looks like a gland like arrangement. If you look at this, this is like an island. This whole thing is a big island. This looks like a follicle. Again, here, do you appreciate the island, the circular island over here, the circular island over here? Now let's zoom in further and see. This is what is the tall columnar ameloblast like cells. Okay, tall columnar ameloblast like cells. This is the dental, the stellate reticulum like cells. This is a single layer of tall columnar cells with the base, with the nuclei arranged away from the basement membrane. Okay, so let's read the legend here. An island of tumor cells stimulates enamel organ formation at the bud stage of the odontogenesis. There is loosely cohesive meshwork in the center of the epithelial island that simulates stellate reticulum, and a peripheral columnar layer that simulates inner enamel epithelium. Okay, so this is how arrangement of follicular ameloblastoma looks. And as this follicle actually grows in size, what happens is there is centralized cyst formation that takes place. Okay, the cells in the center of the tumor island in this picture are spindle to angular shape, simulating stellate reticulum. There is prominent color degradation between peripheral and central cells, and this whitish area that you're seeing eventually leads to bigger cyst formations. Okay, central cystic degeneration, which is commonly seen in follicular ameloblastoma. Okay, I hope you understand what I'm trying to explain here. Okay, because this particular arrangement, if you understand, you will be able to understand all the other ameloblastomas. Okay, histopathological features of ameloblastomas. Okay, right. The second one is plexiform ameloblastoma. Okay, the word plexi means basically a network. Okay, so you basically in this form you see large consists largely of thin trabeculae of epithelium, typically bordered by less well differentiated columnar cells than ameloblast like cells of follicular type. You see stroma consisting of loose, vascular, sparsely cellular connective tissue. Microcyst formation is common and typically due to stromal degeneration. Okay. In follicular ameloblastoma, the word that was used was because of central cystic degeneration. Here is because of stromal degeneration. This is more commonly seen in maxilla, something again different. Okay, now this is the arrangement. Now plexiform, okay, you're seeing the arrangement like a network like cells. Okay, let's look more closely. Okay, the proliferating epithelium often is composed of bilayer of cuboidal to low columnar cells closely simulating dental lamina stage of odontogenesis. There is loose background of stroma and an absence of reverse polarity. So please understand that in plexiform ameloblastoma, there is absence of this reverse polarity of the nuclei, which we just read in follicular ameloblastoma. Okay, so this is another picture here. So you can see the lamina-like strands expanded because of the proliferation of cells between the bilayers. So as we just discussed, plexiform ameloblastoma, the word is because of the arrangement of cells, right? And these cells actually are in thin strands like a network, and you actually see areas that resemble like stellate reticulum in the connective tissue between these strands of epithelium here. Okay, all right, so this brings us to the end of the first part on odontogenic tumors. I thought that we should have small lectures of about 30-35 minutes so that you have time for reflection and discussion. I will start a Google discussion forum on Google Classroom discussion forum on this topic, and please feel free to actually post your questions there so that I can answer those questions before we move on to the next topic. Okay, as I mentioned at the outset, again, this is a very important topic. All right, odontogenic tumors is a very important topic, so please take time and read through hear this lecture out and find time to read it from your textbook as well as from my lecture notes. and understand. Okay, understanding the topic is the most important aspect over here. Okay, so please take care and keep reading. Thank you very much.